Welcome to this session of the Coffee Break series of presentations. This is the first of two presentations devoted to diagnostic testing. First, let's look at the basic features of how diagnostic tests are tested and how, from a scientific perspective, their value is determined. I know what you're thinking. This is going to be one of those long, boring statistical discussions with obscure terms and numbers and calculations that you will be quickly depositing in your circular file. Well, my goal is to reroute that information and package it in a way where it's recognized as relevant and usable. We often approach diagnostic testing like a simple math problem. Take a history indicator and a positive test, add them together, A plus B, and you have the answer C. But we know better. The problem, as any experienced clinician will tell you, is that patients are far too complex for this to occur very often, except perhaps for the less common classic presentations of a disorder. In fact, most of the time we can only get close to feeling entirely correct about our diagnosis. It's more like balancing out the factors that weigh on the side of having the disorder or on the side of not having the disorder. What we'll find, though, is that each of the factors carries a different weight. They're not often created equal and can either have little effect or dramatically shift the scales. When it's time to interpret and apply the stats, we'll see that we have two obstacles. First, gathering and analyzing all the studies that are used to study a test, and secondly, the extrapolation to our patient. So why do we do tests? Well, it seems obvious to determine what's causing our patient's problem, but we realize that there are a host of peripheral factors that determine whether we do or do not perform a test. These include what we're taught, what outside agencies such as managed care, Medicare, personal injury require, whether it costs money, and sometimes, frankly, to cover ourselves legally. But what really determines the value of a test for your patient? It certainly starts with what is known about the statistical value of the test. We'll start with the true purpose of testing without the interference of outside influences and motivators, past prejudices, and tradition. One purpose is to rule out a serious concern, one that would cause me to want to refer the patient. Another is to determine if I can move on to treatment, or does the test provide enough evidence to support a diagnosis and suggest further testing. Instructors of diagnostic testing have a different mindset. How do we determine which tests to teach? Is it just what we were taught? Are they the tests required on a form from an outside agency that drives us to prepare the student for real-world demands? And why were they chosen by that group in the first place? How do we determine the value of each test in relationship to each other, and how do we answer the student question, should I combine tests into a cluster, or is there really one best test for this condition? Well, that's lots of questions, and hopefully a few answers will satisfy most of them. There are really three main steps in the process of testing a test. The first is, are the results valid? The second, what are the results? And finally, if I use the test, is it going to change anything? Is it of value to my patient? For validity, the first step requires that we check to see what types of patients were used in the study. Are they representative of patients with mild to severe forms of the disorder? And are they representative of the types of patients I see? Is there a comparison to a gold standard, and is there an independent blinded comparison to that standard? With results, there's a host of statistical terms that seem mind-numbing in their scope and depth. It's always feared that if one does not understand the math behind these, that they're not usable. Well, that's not true, as we'll see. Can I use the test in my office, and are the patients used in the study comparable enough to the patient sitting in front of me to warrant some extrapolation and application? Will this change anything in the management of the patient? And of course, what, if anything, is this going to cost in time and money? With the evaluation of a test, we look for two benchmarks. Is it valid, and is it reliable? Reliability has two components. When a test is being evaluated in a study of reliability, the examiners may or may not agree. Each examiner, when compared to their past interpretations on the same patient, may not agree with themselves. The first type of reliability, comparing multiple examiners, is the inter-examiner reliability, and the second, intra-examiner reliability, compares the examiner with his or her own past performance on the same patient or group of patients. If the test result is dichotomous, meaning it's either positive or negative, we use a kappa coefficient. If we're looking at continuous data such as blood pressure, temperature, range of motion, the ICC or intra-class correlation coefficient is used. To summarize, reliability then indicates whether I will get the same result if I perform the test and repeat that test at a different time on the same patient, of course not knowing it's the same patient, and that's intra-examiner reliability. Inter-examiner reliability implies that someone else testing that patient with that same test would arrive at the same result as me. Validity has more to do with whether the test is measuring what it's supposed to measure, and this is determined by its comparison to a gold standard. Validity is the degree of trust I should give to the result the test is giving me. Is it sensitive enough to find the disorder? And when positive, is it specific enough that I know it is unique to that disorder? So which comes first, reliability or validity? In other words, which criteria needs to be confirmed first before proceeding to the next? Well, that depends, but if the test does not pass both of these requirements, it simply is of no demonstrable value. It might not surprise you that many tests have never been put to the task of passing these requirements, or even after failing one or both, is still widely used due to tradition and habit. In the past, the sure guarantee of use was a rational explanation for the mechanism of the test, and naming it after yourself or someone else naming it for you. Well, that's great for writing test questions, but useless for determining value. As mentioned previously, there are two ways of representing reliability based on whether the test is simply positive or negative, or whether there's a range of possible findings. Now, what we can do is take the numbers represented by kappa in the ICC and translate them into usable language so that when we see that test result, we can determine whether to trust that the test result is consistently performed and interpreted similarly. For example, a kappa of 0.21 to 0.4 is considered fair, and anything below 0.2 is considered poor. We would proceed with caution in the use of such a test rating. Lucky for us, the ICC produces similar numbers in similar categories, making them fairly easy to determine and use. So, how do we measure a test performance, its ability to rule in or rule out a disorder? Well, we tend to forget that there are really two contexts. One is the study itself, the patients in that study, and the performance of the test in that study. We then must find a way to translate these results into a decision about the patient in front of me, the second context. We can see that in this study, certain statistics such as sensitivity, specificity, positive and negative predictive values, and likelihood ratios and odds ratios are developed from the study setting. If we can add to this the pretest probability, then we can actually apply this to our patient. What we do is develop through likelihood ratios a post-test probability. You've seen this before, the deceptively simple 2x2 table. But what happens when we start putting numbers in these boxes and deriving the dreaded statistical values? Well, you probably are turned off by the math, and secondly by the lack of direction as to why and how you use them. Well, let's fix that. We'll imply some of the math, but only so you can see how it's done. But as we will see, you really never have to do the math. So of course, we have true positives and true negatives and false positives and false negatives. How they're combined determines their value to us. These include sensitivity, specificity, the predictive values, and the likelihood ratios, and at this point are only related to the study. Let's start with sensitivity. By taking both the true positives and false negatives, we account for all patients with the disorder who were tested. Now, sensitivity is the proportion of people with the disease or disorder who test positive. So let's use an unrealistic scenario so that the basic math will be more obvious. Let's say we have 100 patients who all have the disorder. If the test is 84% sensitive, it means that if found 84 of the 100 patients with the disease, but it missed 16. Specificity looks at the number of people without the disease or disorder that test negative. It combines the true negatives with the false positives to total all the people without the disease. Let's assume that again we have 100 patients, but this time none of them have the disorder. If the test is 75% specific, it means that it correctly identified 75 out of the 100 patients without the disorder, the true negatives, but it missed 25% who did not have the disease, but in fact tested positive. So how is this useful in determining the value of a test? Well, first remember that sensitivity and specificity are not affected by the prevalence. This means that it does not matter how many patients in the study have or do not have the disorder being tested. We'll come back to that later. So we have a test and we have a condition. If the test is 92% sensitive and 65% specific, how can we translate that into whether the patient has the condition or not, at least in the study population? Well, we can use an acronym to translate this into usable information. The acronym for sensitivity is SNOUT. That translates into a highly sensitive test when negative is more likely to rule out the disorder. The acronym for specificity is SPIN, meaning that a highly specific test, when positive, more likely rules in the condition. Now we come to predictive values. Unlike sensitivity and specificity, predictive values are dependent on the population who has the disorder, the prevalence of the condition in the study. This statistic gets closer to what we need. This is how these are calculated, and we have both a positive and a negative predictive value. Now we're starting to get a more accurate measure of the value of the test in the study population. Note that a positive predictive value is related to specificity, whereas the negative predictive value is related to sensitivity. In our example, we see that the positive predictive value is 72%, and you may recall that this correlates well with the specificity, which was 65%. They're pretty close. In other words, a positive test rules in the disorder. The negative predictive value is 89%, which correlates with the high sensitivity value of 92%. And so remember, a highly sensitive test rules out the disorder when negative. So let's make this real. Your mother went to the doctor and was told that her test for a disease was positive. She's really worried and asks for your help. After doing some reading, you find that for women her age, the prevalence of this particular disease is 30%. The test has a sensitivity of 50% and a specificity of 90%. So she says on her daughter, "Tell me, what's the chance that I have this disease?" Well, one thing we already know is that if the test is that specific, it tends to rule in the disorder when positive, but maybe we can improve on that interpretation. So let's look at this. We have a prevalence of 30%, a sensitivity of 50%, and a specificity of 90%. Let's use a patient population of 100 patients so that we can take one step out of the math. With a prevalence of 30%, we know that 30 of these patients have the disorder, but that means that there are 70 individuals without the disorder. It's only sensitive for 50%, so we know that the test to be positive in only 15 patients. When we're looking at the 70 individuals without the disorder, we are more concerned with false positive rates with this calculation because we want a total of all positive tests regardless of whether they are true or false. You'll see why in a moment. So the false positive rate is in essence 100 minus the specificity of 90, or 10. So 10% of 70 is 7. Adding the 15 true positives and 7 false positives, we arrive at 22. These are all the patients who are testing positive. So of the 22 patients who test positive, only 15 have the disease. The calculation we will now use is the true positives divided by the total number of positives, and we arrive at 70%. The chance of having the disorder is 70%. Unfortunately, we have some bad news for your mom if, in fact, she matches the demographic of patients in the study or studies used to determine these values. But wait, what did we just do? We just calculated the positive predictive value, and it was relatively painless. So let's try it again. Let's again calculate the prediction that the test result indicates the disease, but this time we're going to change the prevalence only, and we're going to change it to 4%. We'll leave the sensitivity at 50% and the specificity at 90%. If the test is positive, what is the chance that the patient has the disease? So let's go through this again. We've got that patient group of 100 and a prevalence of 4%. Which means only 4 have the disease and 96 do not. With the sensitivity of 50%, only 2 patients with the disease test positive. With 96 patients not having the disease and a sensitivity of 90%, we know that the false positive rate is 10%. 10% of 96 is 9.6. Therefore, 9.6 will test positive even though they do not have the disease. Adding these together, the true positives of 2 with the false positives of 9.6, we have 11.6 patients who test positive. When we divide the true positives by the total positives, we arrive at a positive predictive value of only 17%. See how the lower prevalence decreased the ability of the test to detect the disorder. Now, even though the sensitivity and specificity remained the same, the predictive value dropped from 70% to 17% simply because the prevalence dropped from 30% to 4%. Now, here's what's interesting. A study evaluated medical doctors' ability to judge the chance of disease using the same prevalence, sensitivity, and specificity numbers we just used. They were asked to guesstimate the chance of someone having the disease. With regard to the last scenario, where the prevalence was only 4% and the chance of disease was 17%, the range guessed by the docs was from 1% to 99%, with half the docs thinking the probability was 50%. This illustrates what happens when we use our intuition. Just trust our gut and don't bother with the science and just simply eliminate the math. So let's think about this. All we have are numbers, statistics related to the study, but not to my patient. We have sensitivity, specificity, positive and negative predictive values reflecting the performance of the test in the study population. But we need to do more. We need to arrive at stats that better relate to our patient. We need to create the likelihood ratios. Likelihood ratios are the link between the study and our patient. Although they have nothing to do with the prevalence of the disorder in the patients in the study, we can use an estimate of the prevalence of the condition for our patient, combine it with the likelihood ratios, and arrive at a post-test probability that our patient has the disorder. That's where we want to get to. Also, likelihood ratios are valuable when there's a range of values, such as lab testing, where threshold levels can be established, and likelihood ratio is created for each. So here's an example of the formula used to arrive at likelihood ratios, but we won't spend time with this because it's too much math and unnecessary when applying it to our patients. But I want to point out that likelihood ratios are derived from calculations that use sensitivity and specificity. When you look at likelihood ratios, the range determines the degree to which it influences the probability that the patient has the disorder. It may influence the probability in a small, moderate, or large way. This depends on whether it's positive or negative, but each has a value in determining whether the patient in fact has the disease or not. This is a table version of likelihood ratios, but a more helpful, usable version is a graphical version. So here's an example from the text Evidence-Based Physical Diagnosis by Stephen McGee. We're looking at several things here. What is the weighting here? You can see that the probability may increase or decrease based on the likelihood ratio number. You can see here that a likelihood ratio of 10 or greater is a pretty strong indicator. Look what it does to the probability. It increases it by about 45%. If you go to the other end of the spectrum and look at the LR of 0.1, you can see that it increases the probability that the patient does not have the disorder if the test result is negative. It changes the probability that the patient does not have the disorder by about 40%. But you can also see that a likelihood ratio of 1 really doesn't change anything. It indicates that the test has no discriminative value in determining the probability that the patient does or does not have the disorder. Here's an example for appendicitis. You can see many of the physical exam findings classic for appendicitis, such as McBurney's point tenderness, Rossing's sign, and the psoas sign. You might notice that the positive likelihood ratios for these classic indicators are not impressive. They might increase the probability of appendicitis by only 15–20% if present. A little better is the absence of severe right lower quadrant pain, but that's only about 30%. So you can see why physical exam findings for abdominal pain are often not definitive and why special imaging is so often used. Using the same example, let's incorporate the graphical tool called a nomogram. This allows you to take the pretest probability and draw a line connecting through the likelihood ratio and arrive at the post-test probability. That's where we want to be for the patient in our office. We can see that the pretest probability for appendicitis from the literature is about 5%. Using McBurney's point tenderness as a positive finding, the likelihood ratio is about 3.4. So by drawing a line from the 5% pretest probability through the LR of 3.4, we arrive at the post-test probability, which is only about 20% with that one positive finding. So let's try again. We have a disease with a prevalence of 30% and a test that has a sensitivity of 50% and a specificity of 90%. Well, we already know from what we've already learned so far that if the specificity is high, a positive test is likely to rule it in, at least in the study population. When we calculate this out to a likelihood ratio, as demonstrated here using the formula that includes sensitivity and specificity, we arrive at a likelihood ratio of 5. Remember that this represents about a 30% increase in probability that the patient has the disease when the test is positive. What we'll do now is use a calculator to determine the post-test probability. There are several sites that offer this approach. The one we're going to use is found on the site for the Center for Evidence-Based Medicine. We know that the pretest probability in our example is about 30%, and the likelihood ratio we calculated was 5. Let's move the indicators on the nomogram and automatically calculate the post-test probability. We now see that the post-test probability is about 70%, simply done by using this automated nomogram. Let's try it again. Let's say we have a 20-year-old female who injures herself skiing. There's a pop heard at the time of injury, immediate swelling, and a sense of instability. We suspect an ACL tear, so we'd like to first determine the pretest probability of an ACL tear. But also, since meniscus tears are common with traumatic ACL tears, we want to also know the pretest probability of an associated meniscus tear. Well, based on the literature and the value of the history in this case, we can estimate a pretest probability of 70% for the ACL tear and about a 30% probability of an associated meniscus tear. By the way, these pretest probabilities can oftentimes be found as prevalence through a Google search. So now that we have the pretest probabilities, we need to find the likelihood ratios for various orthopedic tests for the knee, specifically for ACL and meniscus tears. Plug them into the nomogram and produce our post-test probabilities. So here they are, the positive and negative likelihood ratios for two common tests for the ACL and two for the meniscus. We can see that the Lachman's is unusual in that both the positive and negative likelihood ratios are valuable at 42 and 0.1 respectively. Similarly, for the meniscus, we see that the medial lateral grind test has more value than the McMurray's test with a positive likelihood ratio of 4.8 and a negative likelihood ratio of 0.4. Let's use the automated nomogram again. We know that the pretest probability is 70%. Let's assume we get a positive Lachman's on our patient. Moving the pretest marker to 70 and the likelihood ratio of 42 for the positive Lachman, we'll arrive at our post-test probability. We can see that's quite high, 99. We can be pretty sure that our patient has an ACL tear, but what about that associated meniscus tear? Let's place the marker for the pretest probability at 30%. And let's say that we do the medial lateral grind test and we find that it's negative. Well, from our table, we see that the negative likelihood ratio for the medial lateral grind test is 0.4, so let's move the LR marker to that. Well, we can see that the post-test probability is not high. The post-test probability is only about maybe 13–15%. Well, that's helpful in making us feel fairly comfortable that there is no associated meniscus tear, at least for the time being. So here's another wonderful feature of likelihood ratios. We can use the post-test probability calculated from the result of one test and apply it as the pre-test probability for the next test, but only if you're testing different pathophysiologies. Let's use another calculator. This one will provide us even more information and introduce us to the concept of confidence intervals. What we're going to do is enter some of the data that we discussed previously, and we're simply going to fill out the 2x2 table and let the calculator do the rest. So I'll do that right now. So when we click on the Get Results, you can see that all the values we've discussed are calculated. It's magic. All the statistics from the study that were in the 2x2 table are now represented. In addition, we see that the CIs or confidence intervals have also been calculated. We'll discuss their value in just a moment. Simply put, you can take any study where you know the true and false positives and the true and false negatives, plug these into the appropriate fields in the 2x2 table in the calculator, and all the rest is done for you automatically. Another option is a calculator available on the Center for Evidence-Based Medicine site called the Clinical Appraisal Tool, or CAT. The CAT offers the same features and even more options. So what do confidence intervals add to the picture? Well, previous to the introduction of confidence intervals, we were discussing what were referred to as point estimates. You know, sensitivity, specificity, positive and negative predictive values, and the likelihood ratios. What we don't know is the range of these values within the study. So why is it important? Well, when the range is large, it represents a questionable conclusion about the value. The CI range statistically is influenced by the number of occurrences, the prevalence of the disorder in the study population. This is often related to the size of the population, and then that indirectly reflects the power of the study. This strength related to the power of the study is reflected in a tighter confidence interval. In other words, the extremes of the variation are close together. For example, a confidence interval of 7.8 to, let's say, 12.9 demonstrates more precision than one that's perhaps 6.2 to 242. This wide range makes one question the population size, probably too small, and therefore the number of occurrences. And this indirectly indicates some question as to the value of the study because of the decreased power of the study. So up to this point, we've covered much. Some involves math, but there are options that include plugging in basic numbers into an automated calculator. In the end, the intent is to take specific values, such as likelihood ratios, combine with pretest probability based on prevalence, and using a nomogram, come up with the post-test probability. Well, that's nice, but you may be thinking, I don't have time to go through the process for every test. So, has anyone done this yet? Well, up to a point, yes. There are many new books with much of this information provided for you. Here are some examples. There's a caveat, though. Understand that what these texts will do is take you up to the point of sensitivity, specificity, or likelihood ratios. But remember the prevalence, the pretest probability? It's unique to you and your practice, so they simply can't address that issue for you. The best case scenario is when we can guesstimate the prevalence of a disorder in our patient population, combine with the likelihood ratios, and come up with the post-test probability that our patient does or does not have the disorder. So the big question, how do we know the prevalence? Well, taking into consideration the context of your practice helps. If you're a generalist, you can look at the general prevalence in the population as a whole for that disorder. Or if you specialize in, let's say, sports, look at the specific literature for a similar context, such as an orthopedist or sports clinic, to get a better sense of the prevalence in that context. These are sometimes quoted in studies, but they can often be Googled. Just type in the disorder and the word prevalence. A good source is at wrongdiagnosis.com. Well, please review any concepts that are still hazy for you and play around with the automatic calculators, changing values to see the effects before proceeding to the second installment of this presentation, which will focus on diagnostic odds ratios, clinical prediction rules, and other important concepts related to diagnostic testing.